Now, this man who was 54 years old, who was apparently well about a month back, landed up in my emergency for evaluation of severe jaundice and hepatitis. He was seen probably by close to three general practitioners and a specialist in the last 1 month, and they were completely flabbergasted about what was happening to this man. They did not know what was causing the acute hepatitis and jaundice in this person, and so they referred him for advanced evaluation and management to our department. So when I saw him in the emergency, he was well oriented. He was conscious. He was talking about his worries about the disease, the diagnosis that was taking so long to get to, and various medications that he has been on without any major changes to his liver functions. He was a retired bank employee. He stayed about 300 kilometers away from where the hospital where I worked was, and he stayed with his wife and an elderly father. His mother died many years before, and his children were all out of the country. They were working in the Middle East in different jobs. This man had absolutely no prior history of liver disease. He did not have any pre-existing liver disease. And very interestingly, usually we look at family members with liver disease, and there was one family member who had severe liver disease and he died of the liver disease, and that was from his maternal side, a distant uncle. But then he also used to consume alcohol. So that was probably alcohol-related liver disease and death. And this man was a teetotaler. He never drank. He did not have any other associated diseases. For example, he did not have diabetes. He did not have high blood pressure. His cholesterol levels, triglycerides were all normal. And his thyroid functions were normal. He was not obese. He was an average built, adequate weight for height person. But then here he was in my emergency, asking me to diagnose him with whatever was actually killing his liver. So when I looked at his papers initially, and he had done a lot of tests from a lot of places in the last 1 month, his initial bilirubin level, which reflects the severity of jaundice, was somewhere around 4. And over the month, it had actually become 25, which was quite high. Even though the bilirubin levels were increasing, the blood tests are getting abnormal, this man did not show any major features of signs or symptoms of any liver failure. So for us to define a patient who has liver failure, there are 3 things that is necessary. 1, there should be jaundice. That is, bilirubin should be above 3. 2, there is a test known as prothrombin time, which measures the coagulation function, which is the clotting, the bleeding functions related to the human body. So basically, if somebody has a cut in the hand, normally, if it's a well-functioning liver, the bleeding would stop. But if that person has an advanced liver disease or liver failure, then the bleeding would not stop. He would continue to bleed because there is a lot of clotting factor deficiency and the bleeding would continue. So that particular test that reflects that particular clotting factor deficiency or the ability of the body to control bleeds is known as a prothrombin time. I'm just oversimplifying it here so that people understand the basic aspect of it. So if a prothrombin time is high, which is reflected with yet another test known as international normalized ratio, you would see that prothrombin time is always associated with INR. So if the INR goes above 1.5, that means there is evidence of liver failure because there is high risk of bleeds. Now, along with these two, when the patient develops something known as hepatic encephalopathy, that is, the brain also stops functioning well. There is cognition defects or dysfunction. They go into altered behavior. They have confusion. They won't be able to identify their family members. And when that happens, that is because ammonia levels in the body rise subsequent to the liver failure. And that affects the brain cells swell up, and you develop encephalopathy. So when patients have all of these 3 together, we call it as liver failure. That is acute liver failure. But this man had only high bilirubin levels, reflecting his severe jaundice, and also her raised INR. So his INR was somewhere around 2, but he did not have encephalopathy. His brain functions were perfectly fine. So he had something known as acute liver injury, but not acute liver failure. Now the whole aspect of investigation is to identify why this person developed acute liver injury, because he has a normal liver. He had a normal liver all this while, and suddenly now this liver is slow and steadily failing. One more step, that is the brain dysfunction, and he's in acute liver failure, and That's a very serious situation where most patients either die or they undergo liver transplant to improve their survival. So we need to find a cause as early as possible, as fast as possible, before this man went into acute liver failure, so that we can manage him with medications and save his life. But 1 month on, absolutely no clue about what was happening to this man. So I examined him. He was deeply icteric. So icterus is the medical terminology that we use when we appreciate jaundice in the eyes or in the mucous membrane. So some patients will also have yellowishness of the oral cavity of their hands and palms and things like that in very deep jaundice. So basically, this man had jaundice. He was icteric. There was icterus present. On examination, he did not have any flapping tremors. So flapping tremor is something like, it goes like that, just to show you. It's known as negative myoclonus in medical terms. So flapping tremor happens if patients start developing brain dysfunction in liver failure. So it's very important to realize that it's a major sign. But this patient did not have flapping tremors. He did not have any fluid in the abdomen or in the chest. His lungs were clear. His liver was not even palpable. In the sense, palpable means if there's an enlargement of the liver becomes large when it's very inflamed and swollen. You can actually do a clinical examination and figure it out on examination. But this man's liver was not enlarged. His spleen was not enlarged. He did not have any lymph nodes on examination. So we essentially ruled out a few infections and some blood malignancies there on clinical examination. We had to do further in-depth tests. So examination-wise, there was just jaundice and nothing more than that. So we went into the investigations about everything that the other doctors had done for him. And we saw that they ruled out every single common causes that they could think of. For example, acute viral hepatitis. You have hepatitis A virus, you have hepatitis E virus that attacks the liver, causes hepatitis and jaundice. They're usually self-limiting. And they slow and steady go away within few weeks to few months, maybe 4 to 6 weeks time. But this was almost a month and his liver functions were actually getting worse and not getting better. So acute viral hepatitis was out of the picture because one, he did not have fever to start with, because usually patients with acute viral hepatitis have infection which is reflected by presence of fever, and once the fever comes down they develop jaundice. And his tests for acute viral hepatitis A and E, the antibodies were actually negative. They looked at chronic viral hepatitis. So you have hepatitis B and C, you have human immunodeficiency virus, HIV, AIDS virus. All of these were actually negative in him. So they looked at other viruses which typically do not attack the liver, but they do attack the liver in rare instances. Even those viruses were negative. These include herpes virus, cytomegalovirus, adenovirus. So adenovirus was one of the viruses that was concerned with unexplained hepatitis in children post-COVID era. You would have heard the news and you would have read a lot of reports on that. So adenovirus can cause liver injury in some instances. Tests for these viruses were negative. Other causes, malaria, leptospirosis, which is very common in the place where we work, in Kerala in India. Dengue, even dengue viruses can cause something known as dengue hepatitis, where there is severe hepatitis and jaundice, but then it also comes with other issues. You'll have severe high-grade fevers, bone-breaking pains, muscle pains. Patients are usually very sick, but this man was sitting comfortably on the emergency bed. So all of these were negative. So once that happened, the doctors who were treating him sent him to other doctors who were advanced specialists in gastroenterology and hepatology, and they sent out a bunch of tests to look at if this person had other rare liver diseases. For example, there is a group of disorders known as autoimmune hepatitis. So in autoimmune hepatitis, patients develop autoantibodies. So ideally, our immune system is supposed to protect us from invading microbes and pathogens. But in some situations, they become dysregulated and they start attacking us. So these dysfunctional immune cells, they attack our organs and cause immune-mediated damage. So that can happen in the liver too, and it is known as autoimmune hepatitis. So autoimmune hepatitis, there are specific markers for it. An antibody test known as anti-nuclear antibody. There is anti-LKM1 and there is anti-smooth muscle antibody, which is anti-ASMA. So all of these were negative in this man. And doctors had no clue what to do. So they put him on some supplements, some supposedly liver protective agents, put him on good nutrition, etc. But then he was not improving. His liver functions were again going high and high and high, until they figured out that, his prothrombin time and INR was also going high. So that is when he was referred for advanced care. So even we did not have any clues on clinical examination about what was happening to this man. I mean, no pre-existing liver disease. He's not been on any medications in the long term. He's not been on any medications in the recent past that he could even remember. And also, he had no evidence that there was an infection in the body. They also looked at other blood parameters to see if there was any cancer cells in his blood or the body. They did multiple CT scans, and one doctor actually even did a PET scan on him, which is a whole body PET, and nothing came out of it. So he spent a lot of money on investigations without actually getting a diagnosis. So this was a time when we saw him, and it was important to realize that it's not about testing more and more. It's about testing purposefully. If there is a liver disease and we are unable to identify the cause for the liver disease, the next best step is to actually ask the liver. You ask the liver what is happening to you, and we can do that in many ways. And one of the ways is a liver biopsy. So I convinced this man to undergo a liver biopsy. So he was initially scared because the moment you hear biopsy, everybody thinks you're going to diagnose a cancer. But that is not so. A liver biopsy, or there are biopsies done in other organ systems as well, where you don't actually do it to look at cancers or diagnose cancers. You actually do it to identify the cause for damage, the cause for inflammation, the cause for that organ dysfunction, and the severity of that damage. So in this case, I wanted to see in the liver what was actually harming the liver. So what better way than to ask the liver directly. So ultimately we agreed, and we did a liver biopsy. Now the liver biopsy, we do it from the outside. So basically what we do is we give a small local anesthesia around the skin area, and then we directly put in a small needle through the abdominal wall into the liver, and then we take multiple pieces of the liver tissue for us to look under the microscope, under special staining. So this was done, the tissue was prepared, and I asked my pathologist to quickly give me the results, because this man was lying in the hospital without a diagnosis since 1 month, and his bilirubin was climbing and climbing. So within 3 days, I receive a report, and then she says it looks like autoimmune hepatitis. I was like, no, it cannot be autoimmune hepatitis, because he was extensively evaluated for autoimmune hepatitis outside, and even we rechecked all those parameters, and none of those antibodies are positive. So she said, you have to look at triggers or other causes that can actually mimic autoimmune hepatitis in the liver. And so we reassessed his peppers, we reassessed his clinical history again, and we saw that autoantibodies were still negative, and he did not have any autoimmune disorders or autoimmune diseases in the family, among his family members. Or usually somebody who has autoimmune liver disease will have an associated autoimmune disorder like hypothyroidism or rheumatoid arthritis or lupus, something like that. There'll be some history somewhere hidden. But this man did not have any of that. But the biopsy says it's autoimmune hepatitis. Now we go in, and again I sit with him. He's comfortable, but his bilirubin is 30. We sit with him and we ask him again and again and again, and I tell him, please remember, if there was anything out of the blue that you did or you consumed or you took, or something that happened out of the blue, please remember that and let me know. And that is when he said that before he started having this weakness and jaundice developed thereafter, a week before that, for about 4 days, he was on a cough syrup. So he used to get some allergies in the night when because of the seasonal variations in the place where he stays. He stays near to by a hill station. Because of that, he gets allergic cough in the night, and a doctor prescribed him a syrup which he took for a few days. And he had actually taken this once before, and this was the second time that he was taking it. And what happened was that after the cough syrup, a few weeks later, exactly 9 to 10 days later, he developed his symptoms and these jaundice and other complications. So I asked him to show me a photograph of that particular cough syrup. So he showed me a photograph, and the cough syrup actually had a component which is very commonly seen in all the cough syrups that we use on a daily basis, dextromethorphan. Dextromethorphan cough syrup is basically an opioid. It's given for cough suppression, and it's very frequently used in adults. And I've never come across this particular drug causing any major issues with the liver, because it was unheard of. But then you have to look at published data. You can't just make your own conclusions based on your opinions. So I searched the literature in depth and found out that in the United States, a group had actually reported that dextromethorphan use resulted in severe autoimmune hepatitis in their patient. And I was like, okay, now this is slowly starting to make sense. So what we were dealing here with was something known as drug-induced autoimmune hepatitis. So he did not have primary autoimmune hepatitis. So very complex matter in a very simple format. You have autoimmune hepatitis. It can be of various reasons. So you have primary autoimmune hepatitis. That is, you are predisposed to getting autoimmune hepatitis because of genetics, environment, family. It can happen in you at any time, and autoimmune hepatitis can get triggered. So primary autoimmune hepatitis requires treatment for life. Otherwise, you'll have flares and jaundice and hepatitis in between. Now, there is another autoimmune hepatitis where you have risk of getting autoimmune hepatitis, and then some insult comes in. For example, an infection or a drug or some dietary changes, an allergy, whatever, and that triggers the autoimmune hepatitis. So a silent autoimmune hepatitis suddenly becomes triggered. So that is a triggered autoimmune hepatitis. Then you have drug-induced autoimmune hepatitis. So a particular agent or an infection or a drug, it causes the immune system to temporarily dysfunction, leading to autoimmune hepatitis. And once the infection goes away or the drug is taken off and supportive care is given, the autoimmune hepatitis actually comes down, and you don't need to treat these patients for life. But in primary autoimmune hepatitis, where there is actually no cause and it's mostly genetically and environmentally and other trigger related, which can happen at any age, you need to actually treat them for life. So this person did not have any evidence clinically and historically to suggest that he had primary autoimmune hepatitis, because he did not have additional factors that would say that there was evidence of primary autoimmune hepatitis, including the antibodies were negative. There are patients with autoimmune hepatitis where you can have antibodies negative, and that is known as seronegative autoimmune hepatitis. So he had seronegative drug-induced autoimmune hepatitis, and the drug was dextromethorphan, a very commonly used cough syrup. Now we had the diagnosis, so we need to treat. Autoimmune hepatitis is very responsive to steroids. So we started him on low dose of steroids, and based on his body weight, we put him on tapering doses. After 1 month, 2 months, 3 months, we put him on slow and steady tapering doses. And the moment we started him on steroids, his bilirubin started just crashing down. From 30 to 13 to 10 to 5 to 5 to 3 to 2. And by the end of 3 months, it was just 1.6. And then he completely recovered. So what we did was, and what the plan is to put him on a tapering small dose of steroid. We give prednisolone up to 6 months and then slowly stop. So if it was drug-induced autoimmune hepatitis, it would not recur. So if he takes the dextromethorphan syrup again, it will come back again. So that is how you trigger it again. So we advised him not to consume these cough syrup containing dextromethorphan, and he would stay perfectly fine. Now, imagine if it did recur after 6 months. Again, the hepatitis and jaundice came after we stopped the drug or during tapering. That would mean it was a triggered autoimmune hepatitis. So he had primary autoimmune hepatitis, and this drug has triggered it, and now he would require lifelong medications for that. Now, he's doing well, and we were very happy that we could come to a conclusion to this great dilemma that was harming his liver. All this while we were thinking that, we've never thought of this particular drug causing autoimmune hepatitis. But then we went and looked at the literature to see all the drugs that would do it. And I think everyone should know about it. It's so important. There are certain drugs that have definite documentation to cause autoimmune hepatitis. Number one is infliximab, which is a biological agent given to treat various rheumatological diseases, and including some inflammatory bowel disease by gastroenterologist. Second is an antibiotic known as minocycline. Third is an antibiotic known as nitrofurantoin. Nitrofurantoin is very commonly prescribed for urinary tract infection. The important part of nitrofurantoin and autoimmune hepatitis is that you can be taking nitrofurantoin for many, many months to years before there is development of autoimmune hepatitis. So it doesn't happen suddenly as it happened with this man. It can actually happen beyond many, many months and years. So initially there was this treatment protocol for recurrent urinary tract infection where patients were put on long-term nitrofurantoin or cyclical nitrofurantoin over many, many months and years. And I don't think that is an ideal situation now. If you're on these medications for a long term, please talk to your doctors regarding autoimmune hepatitis risk. It's a very rare risk, so don't worry about it. But you need to undergo an assessment for risk for autoimmune hepatitis. The other drugs that can cause include an old world blood pressure drug known as methyl-dopa, another one called hydralazine. So these are the drugs that can cause autoimmune hepatitis. But very importantly, you need to understand that there are plants and botanicals and herbal supplements that can also cause autoimmune hepatitis. Number one of that, among them, is something known as giloy, a plant known as Tinospora cordifolia, very commonly used in Ayurvedic formulations. So if you are consuming Ayurvedic drugs or herbal supplements, please look at the ingredients at the back and see if this particular product contains Tinospora cordifolia or giloy. It is also known as guduchi in Indian market. If you are on this, please stop it, because one, it does not have any benefits, and two, you could land up with severe liver injury. The second herbal agent that can cause autoimmune hepatitis is turmeric. Very rare, but yes, there are a lot of cases that has been reported. Long-term consumption of turmeric supplements, that is turmeric in the form of capsules and drugs in tablet formulations, highly absorbable formulations, nano formulations. Please stay away from those, because if you have any risk of developing autoimmune hepatitis, these herbal supplements can actually trigger it. Turmeric and giloy and etc. The third herbal supplement that can cause autoimmune hepatitis is something known as khat. It's known as bush tea. It gives people euphoria and it acts like a recreational agent. WHO has actually warned people that they should not take bush tea. It is also known as khat, K-H-A-T, because it has psychological dependence and it can also cause severe liver injury, especially autoimmune hepatitis. So please be aware of these agents that can actually cause harm to the liver. Rare but avoidable. And stay safe and stay healthy. Until the next episode, take care and have a great week ahead.